Thank you, Donna. I appreciate it. Good morning. Well, I'd like to thank Pat for inviting me to come speak at the summit. One of the things that I told her when I first met her back, I think in May, I had just gotten back from Afghanistan, and she mentioned that she had this Health Information Technology Summit, and I wanted to tell her, were you not paying attention? I just left Afghanistan, right? I mean, Fred Flintstone would probably make his home there at this point in time. And then I told her that also I work at Grady. As we all know, that when you work at a publicly funded hospital, you don't necessarily have access to a lot of cash. So even when I'm at home, I do not have, I'm not on the precipice of having great technology to discuss with you. So she insisted, and I gave in, so here I stand. So one of the things that I will talk about is not necessarily technology that I am privy to every day, but to appeal to you who are obviously on the precipice of doing great things, already doing great things, types of technology that we would need going forward in an austere environment. So I decided to call this, this talk using wearable augmented reality as a clinical decision support tool for first responders. So let me very quickly take you from this very nice auditorium in a very technical savvy city to a part of the world where technology is still in short supply. And I'm going to take you to Afghanistan and take you through a quick tour of some of the things that medical providers face on that side of the world. This is a slide from the New England Journal of Medicine from 2005. And what you can see is, as you'd expect in any armed conflict, that the primary mechanisms of injury for wounding would be penetrating trauma. But you see gunshot wounds only are 16% of the injuries, shrapnel wounds from things that ordnances that have been exploded, 20%. But far and away, the most likelihood of being injured on that side of the world is from an improvised explosive device, and I will describe what that is in greater detail in a moment. This doesn't show completely, but this is actually from the trauma registry from the hospital where I was located in Afghanistan, which is about 2 miles from the Pakistan border, so you can imagine that's a very hot place to be. You can see, this is just looking at our experience of the US military alone, and you can see that once again, penetrating trauma becomes the most likely way of being injured, but you would suspect if you were in a civilian practice like I have here in Atlanta, that you would expect gunshot wounds, but you can see once again that the IED becomes the most likely way of being injured over there. So exactly what is an IED? The acronym is in the Army, there's always an acronym for everything, is improvised explosive device. So you can see it is anything that is designed to kill you. So here you have on the right of the screen an oil can which has been gutted. Hundreds of nails have been placed inside the oil can. You can see that there is a cell phone basically attached to the C4. So a cell phone can be used remotely to detonate the explosive device, sending the nails obviously at a very high rate of speed to a dismounted patrol and becoming very lethal. Or you can certainly put a tripwire and have it explode that way. The next one is what we call a tank buster, or essentially a tank mine. And what happens here, this is pressure plated, the armored vehicle rolls over it, it takes a shaped charge, which is copper, and that is actually able to penetrate the vehicle. And obviously, if you are the rider inside these vehicles, then you are exposed to penetrating, blunt, as well as burn injuries. So the injuries can be quite horrific. There is no EPA out in the middle of nowhere, Afghanistan, so it is not uncommon to find piles of trash just laying on the side of the road. So here you have a trash bag. Inside this trash bag, you have artillery rounds. You just take some wires. I don't know if this, I've never had to do this before, so I don't know if it'll actually even work. But anyway, I can't do that. But anyway, you can see that you can be very easy to bury a trip wire underneath the sand, and essentially someone walks over that and trips it, and then you have an explosion. The cartoon on the other side of the screen essentially shows several ways of wounding, of triggering these IEDs. One, you can have a pull plate, a tripwire, as I mentioned, pressure plates. And any way that you trip these things off, they have become the scourge of the US military. As I mentioned in the previous slides, you are more likely to die from an IED than actually being shot in Afghanistan or in Iraq. Unfortunately, when these things are planted, they are planted where they are going to not only injure one, but sometimes two, and sometimes many. They can be basically in suicide vests. Someone walks into a mosque, someone walks into a local college and detonates themselves, and you have your first responders having not only one but also multiple casualties who can range in from age from the very old to the pediatric population. So here's a 500-pound bomb, freshly dug earth. If you are on patrol in Iraq or in Afghanistan and you have patrolled through a city or you've patrolled through a road, all of a sudden you see freshly dug earth that was not there yesterday, or a pile of trash that was not there yesterday, a tire, a dead animal. You have to be concerned that this is what is being buried and wait for you. As you can see, it's just a collection. I would imagine this is just one day out on patrol. I can tell you where we were we were in a valley in between two mountains, and we were a blackout fob for operating base, which means at night we can see nothing and you can't see us, which is a perfect time to put these things on the roadside, and of course we go out and we go look for them. And so between about 6 and 10 a.m., you hear about 5 explosions going off. Either we rolled over them or we've discovered them, we've detonated them. So what are the things that I have to be concerned about when I'm over there? How to basically get someone home alive. But the first person they're going to see is not me, it's going to be a first responder. So we have to tell them what are the most preventable things that you can do forward of a medical station to keep a wounded soldier alive. 60% of the deaths are going to occur from some type of hemorrhage. The Kevlar, the body armor, is so good now that it's probably going to protect your core. Your heart, your abdomen are going to be protected. But it's your extremities. It's the ability to pick up your weapon and move that are still exposed. So for those of you who are out there who want to have your house next to Bill Gates, find a body armor that is light and allows you to use your arms. The second would be attention pneumothorax, emergency situation where the lung has collapsed, and I will spend a couple of moments towards the end of the talk to talk about that. And the third would be, obviously, the ability to breathe from some type of airway obstruction. Okay. So what we've all become most familiar with is the car bomb. You basically weight a car down and you basically park it. A bunch of people walk out the next day and you detonate the vehicle. You can see this is an IED that can be easily placed in the side of the road. You have a plaster of Perry. It looks much like the road, basically unidentifiable if you're moving faster than 5 miles an hour. You can see that you have wires that can be attached to that 500-pound bomb or a 2,000-pound bomb, whatever it is that you can find over there to blow up. You can see that the other portion of it has an antenna. So what essentially happens is that now becomes capable of being detonated from a couple of miles off. So this is a video, and I warn you that some of these images are disturbing. So if you want to leave, I will not be upset. But I think it's necessary that you understand what goes on. So here you have, I would imagine, about a 500-pound IED. You have wires coming from the blasting cap attaching to the IED itself, other wires which are available for remote detonation.
Allahu Akbar. Allahu Akbar. Allahu Akbar. وَيَخْشَى الْخَاسِئُونَ.
So here you have overwatch of the road, cell phone ready. You can imagine this, you cannot see this. If you can see this, I've watched this video several times. I've never found it. Use the telephone poles as timing, and you will start to see a tank traveling from right to left. So time it through the first telephone pole, time it through the second, turn on the cell phone, send the signal. As you can imagine, as I stated before, if you're inside that vehicle, if you've actually survived the blast, you're now exposed to burn, penetrating injury from shrapnel, and obviously burns from the explosion. Next slide, please. So, this is a schematic as to how we evacuate people off of the battlefield in Iraq and Afghanistan. I mentioned first responders, but those first responders have names. They are our medics. And our medics are basically very brave men and women who are out on patrol with the units, and they have the primary responsibility for moving people backwards. So one of the things that happens, the medics will basically move them back to a forward surgical team, an FST, where they will see a surgeon for the first time. And they are there to basically stop all life-threatening bleeding, to patch you up, and to basically in a couple of minutes to a couple of hours move you further backwards. Move you back to a combat support hospital, which usually has a runway, because that will be the point of exit from the theater to Germany, then on back to the United States. One of the shortcomings is that's a long flight from It's a short flight from the battlefield to the FST to the combat support hospital, because usually they're only about a couple to 3 miles behind where you're engaging the enemy. But once you get to that flight to Germany, all of a sudden you lose the ability to track that patient. You lose the ability that if something changes in flight for someone either back in Afghanistan who operated on that patient or someone who's going to receive that patient in Germany to understand what happened and how to give effective care in flight. The second part of that long flight is obviously from Germany to the United States. So what do we have to do? So the reason that I'm here today, after following Dr. Dente, it's almost embarrassing because he's obviously at the high end of the spectrum and I'm at the low end of the spectrum. What is it that we can do that is very basic and very simple to keep patients alive? And that's why I decided to come give this talk after realizing that I actually do have something to share with you, and that's we need to assist our first responders, because 80% of deaths in Afghanistan and Iraq, and I've seen some totals quoted as 90%, happen forward of any medical facility. So if you want to bring the sons and daughters of America home safely, you need to somehow empower the first responder with technology that gives them the type of training that a physician may have, the type of training that the tech may have, and the nurse and anyone who is going to provide care for that patient when they finally reach the United States. So what do the medics have to do? They basically have to be lethal. They have to basically help suppress any type of enemy fire, but once that is done, then we ask them to become healthcare providers. They are there to provide care. As you can see from those explosive devices, it has to be immediate and definitive. How do they train? Well, one of the ways that they train is simulation training. Essentially, they learn, as I mentioned, how to be good soldiers first, and the second part is how to take care of patients in a field and setting. But the part of the problem is that how do you take a mannequin or an animal that you have trained on stateside and have those skills readily available when you get to a foreign and austere environment? I could take a medic from Fort Benning, right down the road, one of the most storied bases in all of the world, the armed conflicts the United States has participated in, and say, I'm going to train you at Grady. And in a month of Grady, between the two trauma services, the orthopedic service and the neurosurgical service, that we probably have close to 200 admissions a month. So if you take that number, then you're going to get excellent training. But what happens? I now tell you to go back to Fort Benning. There are no drive-by shootings at Fort Benning. The speed limit is 25 miles an hour. You are not dealing with automobile accidents, and you certainly are not dealing with penetrating trauma. If you look at some of the problems when we study this, is that 50% of what the medic learns can be lost. And outside of that continuous loop of doing penetrating trauma, they lose the ability to maintain these skills. So the Army, wanting to look at their combat medics, decided to have a study where they looked at the 4 competencies that they thought all good medics should have. And it has basically 4 different scenarios. In order to show efficiency in these scenarios, a mastery of these scenarios actually, you had to have a passing score of 70%. And in the process of performing this, that you could not miss any critical steps. So here's one of the studies, 91 Whiskey. For those of you who spend time in the military, once again, there's a number and that are associated with everything. They looked at their young medics first. They looked at the medics who were about E4 or below. The average age was 22. If you look at their educational paths, you can see very few had formal college education, and the vast majority of them had never been deployed. So now you're going to take a 22-year-old, relatively new recruit who's at a place that's in Fort Benning, Georgia, very nice, and I'm going to put you on a plane and say, learn what you did on a mannequin back then. But even when they did that in a controlled environment, I told you that 70% was passing. The average score was 58%, with 66 critical steps missed. If you look at evacuation, almost everyone got that. So they knew how to call for help. They knew how to get the helicopter there and say, hey, I'm overwhelmed, get this guy out of here. But if you look at the actual trauma medics and how they performed, you can see the score is actually the lowest of all the 4 scenarios studied. If you break out the trauma scores even further, I mentioned to you exsanguination from extremities. So in order to do that, you apply a tourniquet. Only 50% of those polled could do that successfully. If you look, I told you the second most common way of dying forward of any medical station is from a tension pneumothorax. The way that we do that is, and I will, once again, I promise, tell you about a tension pneumothorax, is you perform a needle decompression. And you can see that only 50% of those can be done successfully as well. So you have a real problem in trying to train these first responders who basically do not have formal medical education and who are not working at a level 1 trauma center where you do 300 admissions a day. I tell the residents that I work with that I could take you right now and put you in Afghanistan and you would perform well. Why? Because you just do it every day. But if I take this 22-year-old who's motivated, he will not do as well just simply because he does not see what they see. So, now to the technology portion of my talk. So, one of the things that I was introduced to was augmented reality. And I can tell you up until about a year and a half ago, I had no idea. I won't read the slide because I know most of you are saying that you've known about this for 20 years. Welcome to what I already know. But for those of you who do not know this, who are uninitiated like I once was, the simplest way that I can explain this to you is that basically if you've seen computers where people can if you've seen situations where people are plugging things in a science fiction movie, moving the screen in the external environment, well, here it is. This is augmented reality. So basically, you can superimpose stored information out into the real world. And that way you can interact, and not necessarily in the case of what I am talking about for that first responder who's 22, who's never been deployed, who's going to be responsible for 80% of the deaths that will occur forward of a medical station. How do I give him the information that we already know back at the base? How do I interact with him? How do I interact with the young medic or the young respiratory therapist who's now sitting on that big C-130 over the ocean somewhere? Basically, if I can give them some type of information and they can use with augmented reality, then we may be able to get people off the battlefield and all the way home. So one of the things that was introduced to me in my investigation of augmented reality was wearable awareness situation goggles. So essentially, if I am a medic, once again, I have to be lethal. I cannot be blinded to the battlefield. I have to see what's in front of me. I cannot have things shift as I move my head. I have to be able to see any potential threat. I have to, if I cannot recall the information that I learned in Fort Benning, Georgia, I have to be able to somehow activate that with keeping my hands free. So it has to be voice activated. And I have to be, once again, as I've stated several times, be able to superimpose that graphic out into the real world. So here's what we investigate. So this is a schematic of what I was introduced to. These are basically the goggles. You can see inside the frame themselves, they have a little screen, which is programmed to the focal length of the user, and it allows you to broadcast out into the real world whatever information that you want to store in the goggles. There is an earpiece that allows for you to hear. So once you activate the computer will ask you what you want to do next, what you want to do. In this case, we're going to talk about tension pneumothoraces. So I would say to the computer, tension pneumothorax. Obviously, if you are the wounded soldier who is 5'3", and you have another one in your unit that is 6'3", you cannot project the 5'3", or the 6'3", onto the 5'3's chest, or you'll be needle decompressing them in the eye, right? That doesn't help anybody, right? So you can also download onto the goggles the ability of each, have the ability to download the goggles, the body surface area of each individual, what their allergies are, whatever information that you have. This is what was promised to me, but once again, I'm the guy sitting out in the middle of nowhere, Afghanistan, working at the county hospital. I hear what you're saying, but you're going to have to prove it to me. So, what happened? So, when they asked me to look at this, I said, okay, well, I will do my own study. I will do my own pilot study to see if this is actually something that works. It was mentioned during the introduction that I work at Morehouse School of Medicine. Although I'm at Grady, I know that there are medical students over just west of Grady. First year and second year medical students have not made it into the hospital. What do they have in common with the medics? They're a little older, but they're relatively young. Like the medic, they're highly motivated, but their clinical experience is almost negligible. Needle decompressions, as I mentioned, is sticking a needle in someone's chest. I am not about to license someone who's never taken care of a patient to needle decompress someone in the emergency room. But what we do have at the medical school are cadavers, people who have donated their bodies for these type of procedures. So what we did is we took the medical students on a Saturday, just like we would educate anyone else, gave them a PowerPoint presentation. I'm used to it being behind me. I'm sorry, I'm not used to it being over there. We gave them a PowerPoint presentation, and we talked to them about tension pneumothoraces. Once we finished the talk, we asked, had any of them ever had any prior experience in the military, any prior experience with being an EMT or any type of advanced life training? And once the answer was no, once we asked the question, we found 34 people who had not, and we included them in the study. So then we gave them Anatomy 101. So here it is. For those of you who are interested in tension pneumothoraces, after I built it up so well, let me talk to you about it real quickly. So in the middle of the chest, in the middle of your chest, there's the heart. To each side are two lungs. You can see the little, the white structures that are cut on their ends are the ribs. If you get a knife wound, a gunshot wound, a shrapnel through those, that would actually, there's a potential space between those two, and that's where air can fill in, and that would push the lung away. So you have a one-way valve. Air can come in, but it can't come out. Every time you breathe, it comes in and it won't come out. Not to get too detailed on how a blast injury works, but essentially when the blast occurs, if you're in close enough proximity, one of the waves that travels through you basically tears, it shears. So you can have a shearing injury, and this is why you end up with a tension pneumothorax. I wish it was this easy in the real body, but the veins are blue and the arteries are red. So the veins bring blood back to the heart. If you're moving everything to one side, the heart shifts, the vessels shift. They kink, which means if they kink, you can't get blood into the chest, which means eventually you cannot get blood into the heart to pump out. So the death becomes immediate because, one, you have pulmonary failure, and then you have cardiac failure. What we did is when we talked to the medical students, we gave them anatomy. We said, we need for you to stick that needle in a certain spot and nowhere else. These are your clavicles, your collarbone. That needle needs to go in the mid-clavicular line, which is drawn here, and it needs to go in the second intercostal space. We said it over and over and over and over again to make sure that they understood that this needs to go in the exact spot. And I will tell you, just a week ago, I had an EMT who brought a patient in and they stuck it right at the heart, and thank God they just missed it. So it does happen where people put it in the wrong place. And you can imagine that if you are a medic who is young, you're battle fatigued, you have just seen someone you know die, that it would be very easy to forget how to do that, just like the study showed, even in a controlled environment back in the United States. We told them not only are you going to use that second intercostal space in the mid-clavicular line, you're going to take a 14-gauge needle and you're going to stick that in that second intercostal space. So here's what we talked about. Here's the one-way valve. If you don't do this very quickly, then this lung will collapse, it will shift, and this patient will die. And so this is what you need to do. Now, what we did is as I said, we finished the lecture, we identified the patients, and we took them upstairs. But once we finished the lecture, we gave half of them the ability just to walk upstairs and do what you learned. But we also gave them some support. We gave them residents who would basically be on their third year, done a significant amount of trauma. We had a couple trauma attendings, and they could help if they needed assistance. And what we decided, we were going to have 4 steps that we were going to measure. They were not aware of the 4 steps that we were measuring, but just like the medic test that was done by in the Journal of Military Medicine article that I showed you, 3 out of 4 we said was competency. If you needed help with more than one of those, then you didn't show competency. So 75% was the score. We gave the other half the goggles with no instruction. Just put these on, talk, and try to figure out what you learn. So the first slide, like I said, please leave if this makes you queasy. We gave one of the this is one of the medical students who didn't have the goggles. We read them all clinical scenarios. There's a 19-year-old Army Ranger who's violently thrown against a Humvee after an IED attack. He has a distended abdomen with tenderness. His airway is intact, but he has severe right-sided chest pain and is unable to catch his breath. He was requiring emergent intervention for tension pneumothorax. So she's going to try to remember what she learned just an hour ago after a couple pizzas that I bought them and see what she can do. Here's another young man who has a travel version of the goggles, which are battery operated and last about 4 hours, but like I showed you in the schematic, they look more like what I showed you than this now, who basically got no instructions. And you can see he's going to town and he's basically taking that needle, and basically he can see in real time when his head moves without changing the image what he needs to do. And he can actually project what we taught him onto the chest of that patient. In this case, this would be his wounded soldier. This is step number 3. That was basically what he saw. So step number 3, and it looks just like this inside the goggles, and he basically gets a voice prompt and he's able to interact with the computer that tells him to insert the needle at 90 degrees as illustrated, and he will see the needle passing in and out, so he gets an idea as to how deep it's supposed to go, and he can pass the needle. So as I mentioned, 3 out of 4 was considered passing. Anything less than 3 out of 4 showed that that you did not have competency in performing this. Well, you can see that, well, in the red, I don't know if it shows very well up there, but in the red, you have those who wore the goggles and those in yellow who did not wear the goggles. And you can see that 3, if you wore the goggles, you were more likely to complete the task than if you did not wear the goggles. So what we have essentially, so like I said, being the skeptic and the low-tech guy that I am, what someone actually showed me was that I can take a medical novice, program information into a headset that is less than 2 pounds, and give them the ability to do something that is very basic. But very basic is exactly what you need in an austere environment such as Afghanistan. As I mentioned, 1/3 of the mortalities that happen, that are preventable, happen from this disease process. So this is what I believe that people like you who are initiated to augmented reality, who are motivated to do these things, this is what you're here for. This is what we need you here for. So I think that this is a very exciting time. Like I said, I personally am just amazed at what Dr. Dente and his folks do. Then maybe since he's stuck at my table, he'll have to talk to me about how he can come help me at Grady and help to further what we do in the military and overseas. But I was also mentioned during the talk, and some of you saw this, about some shoes being outside and donating your shoes. And when I met Pat, I was actually receiving an award for something that I had just kind of, serendipitously discovered that the shoes were not good in Afghanistan, and said something to some friends of mine and said, hey, just send some old shoes. And the next thing, it's like the commercial, they told 2 friends and so on and so on. So you had a movement over there. But before I finish with that, let me just talk to you about how I think that the first responders over there and what we can do, the first response as to what we do over there also has to be done here. We've spent a lot of time talking about an austere environment, but one of the things that happens is that we have evacuation plans. As I mentioned, you go from Ford Surgical Team to the Combat Support Hospital and on over to Germany. Well, we don't have that type of evacuation program here in Atlanta, right? I mean, we all know that in Atlanta, if you get injured, you're going to go to more than likely Grady, and you may go to Atlanta Medical Center, but for the most part, you're going to go to Grady. If you get 50 people coming to Grady, I can tell you right now, you've overwhelmed the system. Any given day, our ICU beds are at 80-90% capacity. The ORs are running every day. We have 2 neurosurgeons, we have 16 trauma surgeons. Well, we had 16, we're probably down to 12 now. But you cannot bring everyone because they look bad to Grady. We need effective triage. We need someone standing out there with the first response who's actually able to have in real time what is happening, able to look at the scene, which is dynamic and changing, and decide where they need to go. The video that I have, can you run that for me, please? So we spent a lot of money in this country on stopping people at the airport, but let's think about what happened in Madrid. We have someone that gets on a train. You can run it while I'm talking, please. We have someone in Oklahoma who pulls up a van and blows up a building. Now that you're experts on IEDs, figure out where this one is real quickly. There are people on the side of the road. There's a convoy that goes off. That's the I-20 connector on a Friday, or on a rush hour Friday at Grady. What happens if you bring all 50 of those people to Grady? As I mentioned, you're in trouble. That is now, once again, forward of a medical center. We need first responders who are equipped with a ability to see a situation that is changing. the ability for them to look down and actually be able to teleconference back to Grady, back to CHOA, back to Children's Healthcare of Atlanta, back to be able to talk to Crawford Long, where the neurosurgeon may be that day, so they can get real-time information, or they can give real-time information back to the people who are going to be sending these people. If you send a pediatric patient to Grady, I can tell you right now, we're not very good at peds at Grady because we stopped doing it. But it may be better to send that child right up the road to Eggleston. So what we really need is that type of technology, not necessarily in the, well, we need it in the medical centers, but I think what we really need in the military is 4 of the medical centers. I think that this type of technology for our first response, for any given tragedy, when we think about what happened in New Orleans, and obviously what happened recently in Missouri, equipping our first responders becomes a priority. I personally do not have any proprietary involvement in any of this type of technology, but I am just very excited about it, and I think that it would greatly facilitate me doing my job not only here in a civilian practice, but going overseas as well. So, I'd like to thank you for your attention. All right, folks, thank you very much, and I hope you enjoy the summit. Thank you very much.